Hello friends, today we are going to discuss the Espen guidelines for nutrition. So regarding definitions and terminology, all definitions and terminologies used in this guideline document are in accordance with the recent Espen terminology recommendation. Medical nutritional therapy is the term that encompasses the oral nutritional supplements and internutritional and parental nutrition. The two later have traditionally been called as artificial nutrition, but this term is suggested to be replaced by the medical nutritional therapy. Actual body weight is the weight measured during hospitalization and reported just before the hospitalization. So, the ideal body weight is the weight related to the height, and adjusted body weight is applicable in the obese patient and is calculated as actual body weight, that is ideal weight, into 0.033 plus ideal body weight. Through the text, the body weight is defined as pre-admission dry weight for patient with body mass index up to 30 kg per meter square. So the acute phase is composed of two periods. The early period defined by the metabolic instability or severe increase in catabolism, that is if phase, and the late phase, that is flow phase, is defined by the significant mass wasting, muscle wasting, and stabilization of the metabolic disturbances. The post-acute phase follows with the improvement and the rehabilitation or persistent inflammation and catabolic state and the prolonged hospitalization. Isoelectric diet is the energy administration of around the defined target. Hypocaloric or underfeeding is the energy administration below 70% of defined target. The trophic feeding is the minimal administration of the nutrient having beneficial effect, such as preserving the intestinal epithelium, stimulating the secretion of brush border enzyme, enhancing immune function, and preserving epithelial tight cell junction and preventing bacterial translocation. Overfeeding is the energy administration of 110% above the definite target. Low protein diet is the protein administered below 0.5 gram per kg per day. Who should benefit from the medical nutrition? Medical nutrition therapy shall be considered for all patients staying in ICU, mainly for more than 48 hours. How to assess the malnutrition? A general clinical assessment should be performed to assess the malnutrition in the ICU until specific tool has been validated. So the general clinical assessment should include anamnesis, report of unintentional weight loss or decrease in physical performance before ICU admission, physical examination, general assessment of body composition, muscle mass, and strength if possible. So the diagnosis of malnutrition is suggested by the clinical observation and complementary examination. Inflammation is associated with high CRP and low albumin. So the other scores are subjective global assessment, which includes patient history and physical examination. Mini nutritional assessment, that is SF, has surface has the highest specificity. Nutritional risk score 2002 has highest sensitivity. The subjective whole assessment was the gold standard. Now, regarding muscle mass, malnutrition and muscle wasting generally occur during ICU stay due to effect of catabolic hormone. That is an imbalance between intake and the requirement, but also as a result of physical immobilization. Large amount of the lean body mass as well as fat mass may be lost during relative short time during ICU stay. No validated tool is available, but lean body mass evaluated by ultrasound, CT scan, bioelectric impedance, or even stable isotope might be performed to evaluate this loss. This loss of muscle can be considered as a failure. Such a loss in muscle is associated with the prolonged hospital stay and interferes with the quality of life and the functional capability. Sarcopenia is defined as decrease in muscle mass, muscle loss, or function, and is frequent in undernourished patients admitted to the ICU. Muscle function may also be assessed by various tools such as hand grip dynamometer if the patient is conscious, being especially good prognostic factor in conscious patient with ARDS. Bioelectrical impedance can be used to assess body composition, mainly lean body mass, in stable patients not suffering from the fluid compartment. Several studies have described the advantage of bioimpedance and mainly phase angle in evaluation of the prognosis of critically ill patients. However, its use is not in common practice. Recently, CT scan has been used in ICU to assess lean body mass and may be promising tool for patient undergoing abdominal CT. A very recent study showed that the patient with the low muscle mass found at admission have higher length of stay and higher mobility. How to screen for the risk of malnutrition during hospital stay. Every critically ill patient staying for more than 48 hours in ICU should be considered at risk of malnutrition. Non-specific ICU nutritional score has been validated thus far. The existing nutritional tool NRS 2002 and malnutritional universal screening tool that is MUST tool have not been designed specifically for critically ill patients. Recently, a novel risk assessment tool was proposed based on age, severity of the disease reflected by Apache 2, sequential organ failure score, comorbidities, and days from the hospital to ICU admission, including or not inflammation assessed by the level of interleukin. The final composite of nucleic score was correlated with the mortality and expected advantage of the score was to able to show interaction between the score and the nutritional intervention regarding outcome, hypothesizing that nutritional support might decrease the mortality in patients with high nucleic score. Limitation of the score is no nutritional parameters are in. NRS 2002 had low risk of bias in two studies demonstrating malnutritional risk as an independent risk for the greater hospital mortality. It appeared that among all screening tools, NRS 2002 and MUST have the strongest predictive value for mortality and they are easiest and quickest to calculate. When should nutrition therapy be initiated and which route should be used? Oral diet shall be preferred over enteral or parenteral nutrition in critically ill patients who are able to eat. If oral intake is not possible, early enteral nutrition in critically ill adults should be performed and initiated rather than delaying enteral nutrition. If oral intake is not possible, early enteral nutrition shall be performed or initiated in critically ill adult patients rather than early parenteral nutrition. In case of contraindications to oral or enteral nutrition, parenteral nutrition should be implemented within 3 to 7 days. Early and progressive parenteral nutrition can be provided instead of no nutrition in case of contraindications for enteral nutrition in severely malnourished patients. To avoid overfeeding, early enteral nutrition and parenteral nutrition shall not be used in critically ill patients but shall be prescribed within 3 to 7 days. Contraindications: withholding enteral nutrition in critically ill patients with uncontrolled shock, uncontrolled hypoxemia and acidosis, uncontrolled upper GI bleeding, gastric aspirate more than 500 ml per 6 hours, bowel ischemia, bowel obstruction, abdominal compartment syndrome, high output fistula without distal feeding access. Key points should be aiming for oral nutrition as early as possible while considering the risk of the complication. Early enteral nutrition at low rate and progressive increase within the 48 hours if oral nutrition is not possible, while considering the risk of complication. This progressive increase should be out by local protocols. Determination of the optimal starting point and the dose of parenteral nutrition based on the risk of the complication from oral and enteral state of acute illness and the presence of previous under and malnutrition. In adult patient, does intermittent enteral nutrition have advantage over continuous administered enteral nutrition? Continuous rather than the bolus enteral nutrition should be used. Now, the next question in adult critically ill patient, does post-pyrolic enteral nutrition compared to gastric enteral nutrition improves the outcome? Gastric access should be used as the standard approach to initiate enteral nutrition. In patient with the gastric feeding intolerance not solved with the prokinetic, post-pyloric feeding should be used. In patients deemed at high risk for aspiration, post-pyloric, mainly jejunal feeding can be performed. In adult critically ill patient, does the administration of the prokinetic improves the outcome? In critically ill patient with the gastric feeding intolerance, intravenous erythromycin should be used as first-line prokinetic therapy. Alternatively, the intravenous metoclopramide or combination of metoclopramide or erythromycin can be used as prokinetic therapy. The measurement of gastric residual volume for assessment of gastrointestinal dysfunction is common and may help to identify the intolerance of enteral nutrition during initiation and progression of enteral nutrition. However, the monitoring of established enteral nutrition, continued measurement of gastric residual volume may not be necessary. We suggest that enteral feeding should be delayed when GRV is more than 500 ml per 6. In this situation, and if examination of the abdomen does not suggest an acute abdominal complication, application of prokinetic should be considered. Aspen and SCCM and Surviving Sepsis Initiative recommended the use of prokinetic, that is metoclopramide, 10 mg 3 times a day, or erythromycin, that is 7 mg per kg per day, in case of feeding intolerance recommended. The low quality evidence for Surviving Sepsis Initiative and for Aspen and Society of Critical Care Medicine. Both drugs have been shown to be efficacious for elevated gastric residues in an earlier meta-analysis not limited to critically ill patients. Both agents have been associated with QT prolongation and predisposition to cardiac arrhythmias, but large series have only reported few adverse effects such as seizures in neurological patients. The BLESS trial had shown the modification in microbiota of non-cystic fibrosis bronchiectasis patient receiving erythromycin for 48 hours. No such effect have been described after 48 hours. Our meta-analysis based on 6 studies finds a significant advantage to erythromycin and its use should be encouraged for 24 to 48 hours. Since it promotes gastric motility and if large gastric residual volume still persists, the use of post-pyloric feeding should be considered over withholding enteral nutrition unless new abdominal complication is suspected, like obstruction, perforation, and severe distension. In critically ill mechanically ventilated patient, energy expenditure should be determined by using indirect calorimetry. If calorimetry is not available, using volume consumption from pulmonary artery catheter and carbon dioxide production derived from the ventilator will give a better evaluation on enteral expenditure than the predictive equation. If indirect calorimetry is not available, calculation of resting energy expenditure from consumption of CO2 obtained from ventilator, that is resting energy expenditure is 2 into 8.19 has been demonstrated to be more accurate than equation but less than the indirect calorie. The VO2 calculated from pulmonary artery catheter can also be used. In the absence of direct calorimetry, VO2 and VCO2 measurement, use of simple weight-based equation. The simplest option may be preferred. Then, in critically ill patients for whom caloric needs are measured using indirect calorimetry, or estimated using predicted equation, should isoelectric or hypoelectric nutrition be used? If indirect calorimetry is used, isocaloric nutrition rather than hypocaloric nutrition can be progressively implemented after the early phase of acute illness. Hypocaloric nutrition not exceeding 70% of energy expenditure should be administered in the early phase of acute illness. After day 3, caloric delivery can be increased up to 80 to 100% of measured energy expenditure. If predictive equations are used to estimate the energy need, hypocaloric nutrition should be preferred over isocaloric nutrition for the first week of ICU stay. In patients who do not tolerate full dose of enteral nutrition during first week in ICU, The safety and benefit of initiating parenteral nutrition should be weighted on case to case by case basis. Parenteral nutrition should not be started until the all strategies to maximize enteral nutrition tolerance have been attempted. Early parenteral nutrition is associated with increased morbidity, including prolonged ICU dependency and mechanical ventilation, and increased infection rate and need for the renal replacement therapy. The optimal time point for supplementary parenteral nutrition aiming to achieve full caloric need is not clear, but it's suggested to be between days 4 and 7. As a result, Espen recommended that in patients with either low or high nutritional risk, the use of supplemental parenteral nutrition should be considered only after 7 to 10 days if they are unable to meet more than 60% of energy and protein requirement by enteral route alone. This statement is based on evaluation that initiating supplemental parenteral nutrition on the top of enteral nutrition prior to 7 to 10 days after ICU admission does not improve clinical outcome, even may have detrimental consequences. In adult critically ill patient, does high protein requirement compared to low protein intake improves the outcome? During critical illness, 1.3 gram per kg of protein equivalents per day can be delivered progressively. Physical activity may improve the beneficial effect of the nutritional therapy. What are the optimal combinations of carbohydrate and fat during enteral nutrition and parenteral nutrition? The amount of glucose and carbohydrate administered to ICU patients should not exceed 5 mg per kg per day. The administration of intravenous lipid emulsion should be generally a part of parenteral nutrition. Intravenous lipid should not exceed 1.5 gram lipid per kg per day and should be adapted to the individual tolerance. The optimal nutritional composition of micronutrient is defined by minimal requirement at the upper limit. For carbohydrate, the upper limit should be 5 mg per kg body weight per minute, and for intravenous lipid, the upper recommendation is 1 gram per kg body weight per day with tolerance up to 1.5 gram per kg per day. Administration in excess can lead to weight storage or even toxicity. Should we use additional enteral and parenteral glutamine in the ICU? In patients with the burns more than 20% of body surface area, additional enteral dose of glutamine, that is 0.3 to 0.5 gram per kg per day, should be administered for 10 to 15 days as soon as enteral nutrition is commenced. In critically ill trauma patient, additional enteral nutrition of the glutamine, that is 0.2 to 0.3 gram per kg per day, can be administered for first 5 days with enteral nutrition. In case of complicated wound healing, it can be administered for longer period of 10 to 15 days. In ICU patient except burn and trauma patient, additional enteral glutamine should not be administered. The amino acid glutamine is the normal component of the protein, representing around 8% of all amino acid and is present in the standard commercial enteral feed. Glutamine transports nitrogen between the cells and the organ and served as metabolic fuel in rapidly proliferating cells. Under physiological conditions, supplemental endogenous glutamine stores are maintained by both daily nutritional intake and by endogenous synthesis. Plasma glutamine level have been repeatedly been shown to be low during critical illness and low values to be associated with the poor outcome. However, not all critically ill patients are glutamine dependent. Most patients with very high plasma glutamine concentration suffered acute liver failure. As glutamine is one of the most potent gluconeogenic and the urogenic amino acid, liver failure reduces the normal removal of the ammonia produced from the glutamine metabolism. In redox trials, some patients exhibited high level of the plasma glutamine. In major burn studies included the limited number of the patient. Nevertheless, the existing randomized trial have repeatedly demonstrated that glutamine and its precursor ornithine alpha glutarate have beneficial effect in major burn injury, reducing infectious complication and also mortality. In unstable and complex ICU patients, particularly in those suffering from liver and renal failure, parenteral glutamine dipeptide shall not be administered. High doses of omega-3 enriched enteral nutrition formula should not be given by administration. Enteral nutrition enriched with the omega-3 fatty acid within nutritional doses can be administered. High doses of omega-3 enriched enteral formula should not be given on routine basis. Parenteral lipid emulsion enriched with the EPA and DHA fish oil dose, that is 0.2 to 0.1 to 0.2 gram per kg per day, can be provided in patient receiving parenteral nutrition. To enable substrate metabolism, micronutrients should be provided daily with parenteral nutrition. Antioxidant as a high dose monotherapy should not be administered without proven deficiency. In critically ill patients with major low plasma levels, that is 25 hydroxy vitamin D less than 12.5 vitamin is there, then vitamin D can be supplemented. In critically ill patient with major low plasma level, that is 25 hydroxy vitamin D less than 12.5 mg per DA, high dose of vitamin D3 as a single dose can be administered within the week after admission. Enteral nutrition should be delayed if shock is uncontrolled, hemodynamic and tissue perfusion goals are not reached. Whereas low dose enteral nutrition can be started as soon as possible if shock is controlled with the fluid and the vasopressors and inotrope while remaining vigilant for signs of bowel ischemia. In cases of uncontrolled life-threatening hypoxemia, hypercarbia, acidosis, where enteral nutrition can be started in patients with stable hypoxemia, compensated and permissive hypercapnia and acidosis. In patients suffering from active upper GI bleeding, where enteral nutrition can be started when the bleeding has stopped and no signs of rebleeding is observed. In patients with overt bowel ischemia. In patients with high output intestinal fistula, if reliable feeding accesses distal to fistula is not achievable. In patients with abdominal compartment syndrome and if gastric residual volume is more than 500 ml per 6 hours. Low dose enteral nutrition should be administered in patients receiving therapeutic hypothermia and increasing the dose after reward. In patients with intra-abdominal hypertension without abdominal compartment syndrome, various temporary reduction or discontinuation of enteral nutrition should be considered when intra-abdominal pressure values further increases under nutrition. In patients with acute liver failure, when acute and immediately life-threatening metabolic derangements are controlled with or without liver support strategy independent on grade of encephalopathy. Early enteral nutrition should be performed in patients receiving ECMO, in patients with traumatic brain injury, stroke, spinal cord injury, severe acute pancreatitis, after GI surgery, abdominal aortic surgery, abdominal trauma where continuity of GI tract is confirmed, in patient receiving neuromuscular blocking agent, in patient managed in prone position, and in patient with the open abdomen. Regardless of presence of bowel sound, unless bowel ischemia and obstruction is suspected in patient with diarrhea. In non-intubated patient not reaching energy target with oral diet, oral nutrition should be considered first and then enteral nutrition. In non-intubated patient with dysphagia, texture-adapted food can be given. If swallowing is proven unsafe, enteral nutrition should be administered. In non-intubated patient with dysphagia and very high aspiration risk, post pyloric enteral nutrition, and if not possible, temporary parenteral nutrition during swallowing training with removed nasoenteral tube can be performed. Early and progressive enteral nutrition should be used in septic patients after hemodynamic stabilization. If contraindicated, enteral nutrition should be replaced by progressive parenteral nutrition. In patients after abdominal and esophageal surgery, early enteral nutrition can be preferred over delayed enteral nutrition. In critically ill patients with surgical complications after abdominal and esophageal surgery, and unable to eat orally, enteral nutrition should be preferred unless discontinuity and obstruction of GI tract and abdominal compartment syndrome is present. In case of unrepaired anastomotic leak, internal and external fistula, a feeding access distal to the defect should be aimed to administered enteral nutrition. In case of unrepaired anastomotic leak, internal or external fistula, and if distal feeding access is not achieved, enteral nutrition should be withheld and parenteral nutrition may be commenced. In case of high output stoma or fistula, the appropriateness of chyme reinfusion and enterochalasis should be evaluated and performed if adequate. Trauma patients should be preferably receive early enteral nutrition instead of early parenteral nutrition. An isocaloric high protein diet can be administered to obese patients, preferably guided by indirect calorimetry measurements and urinary nitrogen losses. In obese patients, energy intake should be guided by indirect calorimetry. Protein delivery should be guided by urinary nitrogen loss and lean body mass determination. If indirect calorimetry is not available, energy intake can be based on adjusted body weight. If urinary nitrogen loss or lean body mass determination are not available, protein intake can be 1.3 gram per kg of adjusted body weight per day. Blood glucose should be measured initially and at least every 4 hours for first 2 days. Insulin should be administered when the glucose level exceeds 10 mol per liter. Electrolyte should be measured at least once daily for first, like potassium, magnesium, and phosphate. In patients with refeeding hypophosphatemia, electrolyte should be measured 2 to 3 times in a day and supplemented if necessary. In patients with refeeding hypophosphatemia, energy supply should be restricted for 48 hours and then gradually increase. Refeeding syndrome can be defined as potentially fatal shift in the foods in the electrolyte that may occur into the malnourished patient receiving artificial refeed. Each cases of refeeding syndrome, a potentially lethal state, has to be detected early to prevent complication. Therefore, assessment of the nutritional status at admission is needed with schedule for measurement of electrolyte, including phosphate. Studies measuring lab parameter versus not measuring are not available. However, lab parameters are important to prevent or detect severe complications like refeeding syndrome or liver dysfunction related to nutrition, as well as to assist in achievement of normoglycemia and more normal electrolyte values. Repeated measurement of potassium, phosphate, potassium, and magnesium during initiation of feeding in critically ill patients are important to detect development of refeeding syndrome, especially because among critically ill patients, electrolyte disturbances among refeeding are not limited to patients with overt malnutrition. The occurrence of refeeding hypophosphatemia may be considered as warning sign. In RCT, Doing et al. Showed that protocoled calorie restriction for 48 hours in patients developing hypophosphatemia upon refeeding improved survival despite similar phosphate supplementation in wood. Slow progression to energy target during first 72 hours, also called as calorie restriction, should be considered to facilitate control of electrolyte disturbances if refeeding syndrome is anticipated or detected. Importantly, whereas potassium is commonly measured in critically ill patients, measurement of phosphates are less. Undetected and the rapid development of severe hypophosphatemia may lead to death after initiation of feeding, as patient admitted to ICU and often malnourished either before or during admission to the hospital. Missed electrolyte disturbance might explain the dramatic increase in early mortality associated with intensive feeding in the intact trial, including patients with the ALI and not fed for 6 to 8 days prior to the injury. A recent early calorie restriction study showed that electrolyte alterations were less likely to occur with cautious introduction to feeding. Thank you, guys.